So I'm Dr. Christopher Greene. I'm an assistant professor of emergency medicine, and I'm the physician director for the serious infectious disease team at UAB, which is kind of overseeing the ED response to COVID-19, among other serious infectious diseases. Spell my name, Christopher Greene.
So talk with us now, as we've seen more cases in the United States, more deaths across the country, the concern and the threat level we feel here at UAB Hospital.
And so obviously we share the same concern for the folks in Washington State. As far as our concern specific to the people in Alabama, we've been making preparations for weeks now. But specific to the emergency department, the things that we're doing are a couple of things. The first thing that we're doing is we are now cohorting patients presenting with influenza-like illnesses in the waiting room as they're waiting to be moved to a treatment area. And that is not because we have seen any COVID-19 cases. It's just in preparation for, in the event that were to become, we were to have an outbreak in Alabama, so that we had that capacity and that infrastructure in place to be putting patients who are more likely to have that type of an illness in an area and away from patients who do not have those symptoms. The protocols that we've had in place already for screening for COVID-19 specifically, but also for Ebola and the other things that are going on, are ongoing. We have moved that, the second thing that we're doing is we've moved that some of that triage process out to the entrance of the ED, so that folks are being asked immediately upon entry to the emergency department if they've had any exposure risks. Specifically, that's travel history, exposure to patients who've been diagnosed with the virus, or if they have symptoms of COVID-19 or other influenza-like illnesses. And that's to help streamline that process, but also to catch every patient who comes through the emergency department who potentially could have some risk for that virus, for COVID-19. Those are probably the two most important things that are most visible right now. Obviously, we have a lot of, we have a ED-specific plan for in the event we were to have a person under investigation. We have designated locations for performing patient care that would be compliant with the CDC recommendations for minimizing risk to the rest of the hospital and also other patients in the ED. We have specific rooms with airflow capabilities and those kind of things. We're also developing and have developed a more broader outbreak plan if we were to have multiple or many patients, which I think is an important part of planning for an outbreak like this, is having plans in place for if we have more patients than we have negative pressure rooms. How do we deal with that? And I think that's kind of how the whole country is responding right now.
Do you feel like it's just a matter of when you guys may receive the patient?
Yeah, I think that's how I think all of the major institutions are functioning right now. We're planning as if it is going to happen. I think all of our hopes is that it won't. Certainly we're watching the developments in Washington State very closely, and also internationally, because there are multiple countries that are dealing with widespread and self-sustaining outbreaks. And our triage process is being updated multiple times a day based off of where those outbreaks are and what kind of travel history or exposure history would be important for making
this. With a more broad plan in place and those contingencies, how many people are you guys equipped to handle with new protocols?
Yeah, I mean, the answer to that question is a little bit complicated. So the UAB specifically is making plans for if we have one or two patients, if we have dozens of patients, and if we have hundreds of patients. And those types of decisions, obviously, it would be based off of, or how we would manage those cases would be based off of the number of patients, or the severity of illness, and those kinds of things. Right now, I think we have had and continue to have a solid plan in place for managing a number of patients. We're working on developing an inpatient site for managing patients that could potentially be a COVID-19 ward. There's a number of other specific interventions that we're looking at. How to manage the dozens to hundreds of patients.
I'm the director of the Division of Infectious Diseases here at UAB. I think I've met many of you before. Happy to be back. Do you want me to just start out and make a few comments about where we're at? Sure. Jeanne, Jeanne, Marrazzo, Marrazzo.
Yeah, go ahead if you'd like to make some comments.
Okay. So I think a few things are worth updating. First of all, as Dr. Greene just emphasized, we have not had a case here in Alabama of the COVID-19 virus. We have had cases reported in our very near neighbors, namely 2 in Atlanta and at least 2 in Florida. There may be more right now. So that's an important point. That said, we are prepared with the kinds of procedures and protocols that Dr. Greene mentioned, which I think is really good. Other big things that have happened globally, we're now at over 90,000 infections, over 3,000 deaths, and the virus has been documented in 72 countries. The hardest hit countries are pretty much the ones we've been hearing about, including Italy, South Korea, China, although encouragingly there's some evidence to say that the severity of the illness that's presenting in China is slowing down a little bit, which is encouraging because maybe that's a harbinger of what might come for other countries. I guess the other important thing to know is that there's a very concerning outbreak, as I'm sure you've heard, in the Seattle-King County region in the Pacific Northwest. What's really notable about that is not just the fact that they've had 9 deaths reported there, but they have gone back and tested at least 2 people who presented to one of the hospitals there last week and were from the long-term care facility that has been most affected by this. And both of those deaths were actually turned out to be due to the COVID-19 virus. So that suggests that the virus in that community has been essentially circulating for several weeks. Probably the very first case that they detected there, which was now about 3 weeks ago in Snohomish County, may have been the very first index case, but there's been a lot of transmission in the community. So people are obviously very concerned. There's a high level of social distancing that's going on. There is a school I know that's closed in Seattle. So we're all following that very, very closely, particularly as it relates to the healthcare workforce, because that's a really big thing. And the concern, I think, there as well is that, you know, if you start to have healthcare workers get ill, and then you start to have to quarantine healthcare workers who were exposed without knowing it, that's when we really worry about undermining our healthcare force. I think Dr. Greene's emphasis on screening people outside the ER is great, because that's an immediate way that we can cut down the likelihood that that's going to happen. So really trying to get at that early on. So the Seattle situation, the global situation, no cases in Alabama. The other thing that's really big news is that the CDC has opened the floodgates for diagnostic testing. You've probably heard that. We still are having very hard time getting people screened. We've only managed to screen about 7 people here, which is really hard, even though we've wanted to do more. The process for getting the test right now involves filling out a form, sending that to the Alabama Department of Public Health. That goes to the CDC, and then we get a determination of whether we can actually test that patient. We anticipate that in probably 4 days, optimistically, we may have access to the test to be done here. One of the major manufacturers of the test that we use to diagnose regular flu, as well as some other respiratory viruses, has added the coronavirus assay, the COVID-19 assay, I should say, onto that swab test that we use. Hopefully our lab will have that running up early next week. We're also developing our own test here at Children's, has an excellent virology lab, which should complement that, and I hope will be online early next week too. So that, I think, and I keep reminding people that we don't know what the true number of infected people is for this virus, right? The only people who've gotten tested are the people who get through that gauntlet of asking CDC to test, right? So you can imagine that there are a lot of people that we would like to test that we haven't been able to test. And when we start to do that, we're almost certainly going to find some cases. So I think people should, again, be prepared. And I think I said this last week, I probably sound like a broken record, but be prepared as the testing rolls out, just like we're seeing in other states, because a number of state labs are doing this test. We probably are going to see an increase in the numbers. That doesn't mean that there is rampant wildfire spread. It may just mean that we're detecting more cases as testing is rolled out.
Dr. Marrazzo, can you explain why it's so difficult to get people through that tedious screening process for testing to happen?
My impression is that it's been essentially two things. First of all, CDC is completely overwhelmed with testing requests because they have established themselves as the only place up until now that could do the test. So that's the first thing. The second thing is that in the initial approach, they were requiring a very rigorous confirmation sequence, which is where they got into trouble with having that required for every test. So they've sort of loosened that process now, and they've opened the door to other labs doing it. So that's really been the backlog.
Do you think the CDC, go ahead.
Where does the vaccine stand right now?
So the vaccine, there are several vaccine candidates, but there's one in particular that is made by a company called Moderna that the NIH is coming very close to being ready to implement in a phase 1 vaccine trial, and I'll tell you what that is in a second. This is a vaccine that looks very good in animal models. It has never been in humans before because we've never seen this coronavirus before. So it's pretty remarkable that given the fact that we just heard about this virus in December, that we actually have generated a vaccine that we hope will be active against this. The way that you study these vaccines is when you have a product that has never been in a human before, you have to put it into a small number of healthy humans and make sure that it's safe in a small number and that it elicits some protective response. So the very first study, which we hope will start up in April, I think is safe to say, probably will have 30 to 40 volunteers, healthy volunteers. If it looks okay in that study, then they will proceed to a phase 2 study, which typically involves several hundred people, and you start to look at additional safety and you start to look at measures of whether they're mounting an immune response. Phase 2 study will probably not be done until at least a year and a half, if that. So vaccine development can be quick, but testing it and giving people time to generate their immune response can take a while. So that's where we're at. I think it's really important, though, to acknowledge how quickly this has rolled out. I've never seen anything come out of NIH this quickly, and they're really fast, so this is good.
Can you
Is this
reiterate
vaccine
how
you're
you would alert the public if we do have a positive test here? I know some people got some text messages.
Yes, there have been some apparently bad fake media attempts to make it sound like we have a patient here. I think for us, the plan would always be to respect the patient's confidentiality, always. The patient comes first, while being responsible stewards of public health and communication. So I think the approach from my perspective, and I'm speaking as a physician, not a media person, or a spokesperson, the approach would be to make sure you have the situation under control, you know what's going on with the patient, you get as much information as you can, and then assuming we have everything there done, I think we would want to let people know. And it's almost, again, I echo Dr. Greene's point about, I think this is a matter of when, not if, given what we're seeing everywhere.
This vaccine that you mentioned, is this the same one that a UAB doctor played a role in developing?
So I don't know that a UAB physician or a research team played a role in developing this vaccine. The vaccine that I am aware of going forward to be tested is from a company called Moderna. But they are working with a clinical trial group, so a research group that we are part of here funded through the NIH. So connected to, but not developed. Yeah, thanks for clarifying that. Did that answer your question about the positive patient? Okay. Yeah, so I was on a plane in Atlanta last night, was wandering around the Atlanta airport. It was interesting, it looked actually pretty normal. There were not very many people with masks. I guess my answer would be right now, there are some institutions and some companies that have restricted domestic travel for that very concern. I think that it is too soon to say from my own perspective. I mean, I obviously traveled last night and I felt safe, mostly because Again, in the next few days, we're going to see an avalanche, I think, of test results, and we're going to get a much better sense of what the community burden of this infection is. So if we find out, for example, that we have a number of mild cases here in Birmingham, which, conceivably, we started testing a bunch of people, we could see, then whether you're here or whether you're in the Atlanta airport or whether you're in, any place, doesn't really matter so much. So I think we'll find out a lot more, and it's just really important to keep your eye on the news and try to get a sense of what's going on. I certainly want to emphasize again that I did have my hand sanitizer with me in the airport. I sterilized everything around me. I used it. I washed my hands. So remember, again, try not to shake people's hands. If you are around somebody who's sick or is obviously sniffling, coughing, looking like they should be at home, get away from them. Yeah.
Anything else?
To mention is to let you know that the NIH is moving forward with a trial of at least one experimental drug that has been developed. I mentioned this recently, but there were some drugs that were developed for the Ebola outbreak that turned out to be not so great for Ebola, but looked pretty good against this virus in animal models again. So we're very hopeful that that trial will get up and running soon, and that will enroll people who are hospitalized with this virus. We hope to be able to do that here, but more on that soon as we find out. Okay, thank you. Yep.